Hi, Dr. Chris Gallagher. Hi, Rohit. Welcome, listeners, to our podcast. And this is, our sixth season of the Big Unlock podcast. We are up to 180 plus episodes now. Really happy to have Chris on our show today, and looking forward to a very interesting and engaging conversation about telehealth and, telemedicine, virtual health, and AI in, how AI plays out in these fields. So we'll start with very brief introductions. My name is Ritu M. Oberoi. I'm the co-host of the Big Unlock podcast and the managing partner here at Big Rio and Demo. And with that, I'll hand it over to Rohit. Thank you.
Yeah, hi Ritu, hi Chris. Great to be on this podcast. Looking forward to an exciting conversation. I'm Rohit Mahajan. I'm the CEO at Demo and Big Rio and the co-host of this podcast. So over to you, Chris.
Well, good morning, and Rohit and Ritu, thanks for the invite and looking forward to the discussion here. Just as a quick introduction for the listeners, so Chris Gallagher, I'm the founder and chief strategy officer for Access TeleCare.
Great. So let's jump right in, Chris. It's always, our listeners love to hear origin stories, and they like to really hear how doctors can possibly have the bandwidth to, understand technology to really bridge this, fields between AI, tech, and medicine. So would love to hear, how and what inspired you to get into tech, and how do you see your role, from this new perspective? Thank you.
Yeah, so I'm a cardiologist by training. Did medical school out in West Texas at Texas Tech Health Science Center, and then did all my postgraduate training at UT Southwestern, where spent nearly 10 years training to become a cardiac electrophysiologist, so a heart rhythm cardiologist. And for me, technology has always been something that's been a passion or an interest of mine, kind of all the way back to my childhood. And I can remember the day when the first computer came into our house, and just spent hours, with really no functionality, but just enamored with what was possible. And I think that's something that's always stuck with me and been in parallel to my medical training. And when I started out, really saw heart rhythm therapy as a field that melded the two, technology and medicine together. And it was procedural based. It was always cutting edge. You were in a lab that looked like something from the Starship Enterprise, just screens everywhere and all sorts of incredible technology. And that really drove me. And in my final kind of years of training, I did a lot of work in rural health, and began to spend time weekends in rural communities. You could drive an hour or 2 hours north, east, west, or south of Dallas, Texas, and find a community that was underserved. And for me, it was a great way to spend time on the weekends, earning extra money while I was in training, but also taking care of underserved patients. And what I saw really was kind of it was striking to me. We saw the same kind of level of complexity, the same level of severity of illness in rural communities that I saw in one of the largest training institutions in the United States. And I just kind of was under the bias that that type of disease pathology didn't exist in those areas. And in fact, it did. And in some cases, it was more severe because it had gone untreated and perhaps undiagnosed. And this really became a passion of mine. And I spent more and more time out there, began to recruit my colleagues to help and cover this hospital. And what we found is that while we were very comfortable managing very sick patients, when we left, the existing or kind of local medical staff didn't have the same level of comfort. And so we began to try to find ways to help them, to boost their medical staff, to recruit physicians. And it was just after a year unsuccessful. And so we began to look at telemedicine as an opportunity to apply to the hospital. And after many trials, and it's its own story, we ended up building the first virtual ICU in Texas in 2013. And
Wow.
And on its third night in place, saved a life. And from that
Wow.
moment forward, it really was this. I think this is what I want my career to be dedicated to, is this virtual care space, managing underserved, untreated populations, and really with a focus on high acuity. So hospitalized patients that are in the sickest moments, scariest moments of their lives, and that's how I got started. And that was the kind of the initial program we launched. It's still running today, nearly 12, nearly going on 13 years later. But really was the genesis for our organization and propelled us forward.
Wow, amazing story. But generally, we hear from everybody that, COVID was what kind of normalized telemedicine and made it very acceptable to people. But you were saying 2013, so that was like way before. So did you, have to really educate people on that? And how did you like convince people that, this could even be possible?
Yeah, we were very early to the party.
Yeah.
And in some cases we were a little too early. And I think kind of convincing people that this could work, absolutely. And when you start new things, you're just throwing everything at the wall and you'll see what sticks, right? And I think that's just kind of par for the course when it comes to innovation and technology. But when you pair that with patient care,
Mhm.
there's a lot of resistance to change in healthcare. And so how do you do it safely? How do you do it to demonstrate that it's not inferior to existing treatment modalities or models of care? And so we had to work through that very carefully. And we only worked in that one single ICU for the first year to
Mhm.
demonstrate like outcomes, to demonstrate safety, to demonstrate efficacy, just demonstrate ROI. And after we had convinced ourselves of that, then only then did we begin to talk. And you're absolutely right. The years of 2014, 15, 16, it was a lot of explaining what this is. Is this real?
Exactly.
Is this real medicine? Absolutely. We began to see an inflection point around 2018 where kind of more and more buy-in around virtual care models we began to see with the health systems, where we did less explaining and more selling and more implementing. And that for us was truly a turning point. But COVID absolutely light years kind of advancement with that in terms of just exposure, probably accelerated the adoption of virtual care by at least a decade. And
Yeah.
and so, yeah, we're obviously in a much different place today.
Mhm. So I read your LinkedIn article about, the physician distribution and how you feel that, there are physicians, but they might not just be there, on the ground. And if you increase access through virtual care, a lot of these physician distribution problems can be solved. So we would love to hear more about that. And also like what you were talking about, being ahead of the curve and really like finding these new technologies. This also sounds so reminiscent of where we are with AI today, because we're exactly almost in that same space trying to convince people that, this new technology and this can work. So it's amazing that you've already been through one iteration of that. And what are your thoughts? So two questions, but you can answer them, in
Yeah,
whichever way you prefer. Yeah.
yeah, maybe we'll start with the kind of the how it relates to where we are today with AI. And I think that um, you know, for us, it kind of the accelerator to virtual care really was just getting more and more people to use it.
Mhm.
And that really was making it as user friendly and reliable as possible. And so user friendly not only on the physician or the nurse practitioner on the provider side, but also on the patient side or the facility side, right? It had to be simplistic and never fail. And so we use this analogy in the early days, which is the system just has to be Fisher Price easy, right? You push a button, the cow goes moo, everyone's smiling and laughing, right? Like that was really kind of our vision for virtual care. And when we started in 2013 with our very first ICU program, it was 27 steps for the physician to have an encounter, and it was 13 steps for the nurse on the patient end to have an encounter. And so it wasn't simplistic. There was a lot of friction,
Yeah.
and it was really inefficient. And so I think as we had more encounters, as we simplified, as we made the user experience better and really just push button easy, that's when we started seeing adoption pick up. And then as adoption picked up, that's when we started seeing more and more kind of self-perpetuating work. And I feel like that's very similar to what we're seeing now, the kind of the crescendo of demand for
Yes.
AI-driven solutions across
Mhm.
all aspects of not only our business lives, but our personal lives just is like ever growing, right? There's a thirst that's just, I think, unquenched right now. And there's also like this amazing interest of, how could we use this tool? What's a new use case? Like, how could I apply this? We're having these conversations in our organization nonstop. And, the list of wants and desires is, it doesn't fit on one page anymore. And so on our end, it's really trying to like, where do we focus? Where do we see the greatest value creation? And where do we want to really apply our resources and energy? So I think very similar. But at the end of the day, it's just getting out there, using it, and not overplan and just like let it go. I think there's some guidelines and guardrails around governance, security, privacy that like we're talking about in healthcare that we want to make sure we have that. But after that, we really want to unlock the user's opportunity to kind of just apply it, see what works, see what doesn't, and keep moving forward. I think as it pertains to kind of the first part of the question, which is around just physician distribution. And I wrote that post because a lot of what we see in an ever-growing number of our use cases is to augment in-person staffs. So when we started, and the story, as I shared earlier, was about rural health. And I think when people think about virtual care, they think about rural care, they think about underserved communities. And that absolutely was our predominant area or patients or population that we serve. But over the last 3 years, we've seen a shift. We've gone from being 70% rural to now 70% urban. And that that shift has happened over the last 3 years. And so where we see the use case for virtual care in terms of like facility-based acute care telemedicine that we do is it's either a rural facility that has no services, right? They don't have a cardiologist, or they don't have an ICU, or they don't have a neurologist. And so we go in and we build that program. So it's a 0 to 1 issue. But the more and more use cases are, a hospital says, we have needs for infectious disease. We have one infectious disease doctor. That doctor can never take a day off. That doctor never can have a weekend off, can never take a vacation. So we can come in and allow that physician to work maybe 3 days a week in the hospital, 2 days a week in clinic, or allow that physician to go 100% clinic focused, and then we manage the hospital. And so it's really what we see is this programmatic approach, this envelope of care applied to every kind of healthcare system, every hospital, where they never have gaps. And they're not burning out their physicians to assure 24/7 coverage of their hospitals, to assure there's no gaps in their clinics. So that's really been our focus. And it's been this augmentation of, well, you have one doctor, but if we bring you another 1.5 virtually, now you have 2.5 FTEs, and your shortage is gone. And then we see a lot of hospitals that they have, 1.5 FTE worth of needs. And instead of burning out that physician working 1.5 times, that physician can work a normal amount, the 1 FTE worth of work, and we can bring 0.5 FTEs. When you're thinking about a hospital, it's 24/7. 66% of the time a patient is in the hospital, it's a night or it's a weekend, right? And so those are the times that most people want to have down, right? They work Monday through Friday. They might work, 50 hours plus a week. They need time for rest. And so that's where we can come in and really augment. And so timeliness is so important. And you can't staff fully 24/7. It's irresponsible. It's outrageously expensive. But you can staff virtually 24/7 and do it in a kind of a dose dependent fashion, use what you need and not have any extra expense.
Sounds like a brilliant solution. I mean, I wouldn't see like any downside to that at all. So looks like you really have something going there.
Well, I appreciate that. Like all logical things, there is some change management, and so we work through that. And I think that applies to all new technologies. Just kind of the change barrier, and once you hit that tipping point, it definitely opens up. But that does take a certain amount of momentum.
Yeah, particularly so in healthcare. I think we've heard those
For sure.
stories over and over again. Yeah, Rohit, would you like to ask a question?
I think this is the perfect segue, like Chris just mentioned, new technology. So perfect segue to talk about, how, Chris, you are looking at new technologies like AI and Gen AI and complementing and adding to what you're already doing. So would love to hear your thoughts about how this infusion of new technologies can change the landscape or the ground rules in the next few years.
Yeah, we see like so many others, just immense opportunity and possibilities. And we see opportunities within our back office functions to simplify and streamline, kind of the business of medicine. We also see opportunities to improve the provider, our physicians and nurse practitioners, of which we have nearly 800, improve their
Mhm.
experience, simplify their experience as it comes to patient care. And then we also see opportunities to enhance patient care itself, to expedite patient care through new technology advancements. And so those are various work streams we're looking at. I think as we kind of like talk about back office, we've already begun to implement and develop and design, and the same with our direct patient care as well. So it's really an exciting time. We've got multiple different pilots and some items that are live and functioning within the organization.
So, Chris, we've been hearing, the top trends for AI for 2025 and 2026 now. And agentic and, voice agents are always on top of the list, and we are particularly interested in voice agents. So, have you tried any of those technologies, and what do you feel or think about those, and what direction do you think those are headed in?
Yeah, we're definitely optimistic about voice agents. We have been meeting with all the various vendors to have those discussions. We have piloted, and so we're in the process of kind of running a few pilots to see, kind of what the impacts are, what's the best fit for our physician group and nurse practitioners, to see kind of which one is best, and then we will integrate that into our platform kind of once we decide which direction we want to go, so that our physicians and nurse practitioners, when they're working, that's one kind of enhancement to experience, but also to efficiency in their workday.
So, have you been seeing most cases in like the digital front door in terms of patient scheduling or, follow-ups or no-shows, or what are some of the other use cases you've been seeing voice agents being used for, or what do you think can be used
Yeah,
for?
yeah.
Or
So we
generally
have
agentic AI as well. Yeah.
Yeah, so we have some that are around, we're looking at in terms of revenue cycle,
Yeah.
and managing kind of various functions within our revenue cycle. So that's an opportunity. You know, our
Right.
our digital front door
Mhm.
is actually comes from the hospital. And so this year we will have over 1 million video encounters with our hospitalized and clinic-based patients. So our kind
Wow.
of patient population is
Mhm.
100% facility based. So they're either in the emergency department, they're in an ICU, they're on the hospital floors, or they're in a clinic. But by and large, our inpatient work is unscheduled, and so we really, the hospitals, it's an inbound from the hospital saying, hey, we have a patient in the ER we need you to see. And kind of the old
Nice.
fashioned way to do that would be a phone call. And
Mhm.
when you think about 1 million visits a year, that's a lot of phone calls, right? So we
Yeah.
we have shifted to where over 50% of our consults today run through automation. So all of our schedules are connected to our platform, and kind of all the consult requests are digital. And so integrated directly into the EMR. So we think about Epic or Cerner, press one button, routes directly to our system. Physician gets, app on their phone. They can swipe, yep, I accept it. That can happen within, literally seconds, that we're distributing from the hospital request to physician set, saying I got it, and then they get on screen and see the patient. 50% of our consults are very complex in terms of where do they go. There's a lot of load balancing. So we have some automation built, but this is where we really see AI. And so that's where our kind of AI opportunities in terms of better patient care. This will expedite our ability to see patients probably 20% faster when we think about emergencies, such as acute stroke or other emergent conditions. We have hospitals where we cover cardiac arrest remotely. And so this will expedite our distribution of those, that workload. And we know that, time to bedside matters. The quicker we can get to bedside, the better the patient's outcomes. And so that's like a direct, real area where we see technology, specifically AI, augmenting all the automations we built for years, to make us even quicker to get to bedside. So that's an area where we're really, really excited to apply this technology.
Great.
What
So
are
this
some
was
trends? Yeah, go ahead, Ritu.
no. I was just absorbing what Chris just said about because this is very different from what we normally hear with the patients being home and scheduling appointments at their convenience. But in this case, like Chris is saying, most of the patients are either in the ICU or on the floor or in a clinic, and something's actually happening to them, and then they kind of contact the doctor. So, Chris, when they go to this virtual doctor, then do they also have somebody by their bedside who's like relaying the actual physical symptoms to the doctor, or how does that work? I was just curious about that.
Yeah, that's a great question. So,
Mm.
our providers are remote. In each hospital, we typically have an access cart. So we have a 6-foot telemedicine cart. You can think of it as the virtual doctor. So 24-inch screen, hand tilt zoom camera that the physician can remotely monitor. They can read 12-point font from 14 feet away. So they can see everything in the room, monitors, if it's a ventilator, they can see that. They can do detailed physical exam findings. And then every cart also has a stethoscope. So it's a digital stethoscope, USB connected. We can listen to the heart, we can listen to the lungs to do a
Wow.
true exam. And so we'll always have a patient presenter in the room. Typically, it's a nurse or a medical assistant to do the exam. But in some cases, we will have, say, another physician. So for the ER, we may have the ER physician. So we always have hands that are available to help us with the
Right.
exam. But a lot of the exam, all of the history we can do remotely. A lot of the exam we do ourselves. All of our physicians have access to the hospital's EMR. That's part of our workflow.
Mhm.
And so they're reviewing the records, they're doing the documentation, the hospital's EMR, they're putting in their orders, they're managing. And so it looks and feels as close to an in-person provider as possible. And that's really kind of like our two kind of North Stars throughout all of this have been Fisher Price easy. But then it has to look and feel as close to in-person medicine as absolutely possible. So kind of everything you would expect if a physician or a nurse practitioner walked into your room, we should
Yeah.
expect that with these models, these virtual care models as well.
This is really interesting because otherwise, in your head, the image of telemedicine you have is just a screen and, a person talking to you. But in this case, you've really taken it to the next level. So that's really good to know. Thank you,
It's
Chris.
been absolutely, and for us, it's been it's been really important. I shared earlier that so many of the patients we manage were rural, and now today it's about 35%, but 82% of the patients we serve are underserved. They're either uninsured, they're Medicaid, they're elderly populations. So it's for us, it's been really rewarding to build these programs that we know reach patients when they need it and helps with equity, health equity issues.
Right.
It helps, but also we know that when we launch these programs, it helps keep care local. And so
Mhm.
patients aren't being transferred, right? So they're not being transferred to another hospital to receive specialty care. They're receiving it right where they went, right? Their home community. And so they don't have to get on an ambulance. They don't have to get on a helicopter. And a helicopter can be $30,000 to $50,000. So we know that every time a patient transfers, that's the costs increase $5,000 for that episode of care. So for a $200 telemedicine visit, we can avoid $5,000 in transfer expenses. So it's a really straightforward ROI.
Yeah. Great. Thank you, Chris. Rohit, you can ask your question now.
Yeah, I was just thinking about the trends, the trends which, or any patterns that, Chris, you might be spotting, or any strategic things that you might be thinking about from the next year perspective, on how the business will transform itself to
Yeah.
the next level. So any thoughts or ideas around that would be great to know.
Absolutely. So we are definitely see today that virtual care models are being woven into the everyday fabric of healthcare, right? So whether it's outpatient clinics, it's home-based care, it's hospitalized patients, inpatient care, there's not only an openness, but in many cases an expectation that virtual care models will be part of that, right? And so what we're seeing are health systems embracing this hybrid approach towards care, right? So And in some cases, we're seeing systems talk about virtual first. And so conceptually, the way we've begun to think about this virtual first approach is that there's a kind of a baseline level of care that we can assure to every patient that walks in the door if we have a virtual option available, right? So we know that we can assure that there's no gaps, that every specialty, every non-procedural specialty a hospital can have. And then you layer in the in-person team members. So if you need procedure-based care, you can have a proceduralist. If it's high volume care and you need some in-person team members, then you add some in-person team members. So it's a kind of a programmatic approach, thinking about each of your specialties, and then this virtual first approach. And so that's, I think, new. That's not something that was even on the table 2 years ago. But we are in conversations with multiple systems, and this is part of their strategy. Where can we go virtual first? How do we evolve our organization to think this way? And it gets back to that distribution issue, is that if we're distributing physicians in an inefficient way, which we haven't changed our staffing models for a century on how we staff patient care inside of hospitals with regard to physicians. We know it's inefficient. And sometimes we're either overworking the physicians or nurse practitioners and they're burning out, or we're paying for them to be available and they're just not busy, right? So none of that makes sense. And so we can dial in the right amount of care on the edges with virtual care, or we can start with virtual care and then layer in kind of the more limited resource, which is in-person physicians. And that's, I think, where we're seeing these conversations about virtual first really, really take off.
Awesome.
Great. So I think we've almost reached the end of the podcast. So Chris, if you would like to share any closing comments or, any other thoughts for our listeners, that would be great.
Yeah, I really appreciate the opportunity to connect with you guys and to share a little bit about our company and also talk about how technology is impacting us. And I think we are, on this topic of AI, like so many, just really, really bullish about what it can do to enhance the efficiency within our organization, but also improve the experience for physicians. And I think that ability to improve physician experience, I think, is one where I think we're going to see tremendous returns as it impacts direct patient care. I think it really is going to enhance the patient's experience ultimately. And I think that's kind of what we're all in healthcare are about. And I think secondly, I think we talked earlier about COVID, but what that did is really transform the kind of the resistance to change within healthcare. Is there's just such an openness to embrace technology today that didn't exist 10 years ago. And
Right.
I think this really is a turning point moment. There's been a few of these moments in time with medicine. And I think probably we think about the era of antibiotics is one. Another was surgical technique, which is, 150 years ago. Like, this is a really important turning point, and excited for the future.
Awesome. Awesome.
Yeah, those were great insights. So thank you, Chris. Thank you for being on our show.